I would like to thank Dr. Armen Hovhannisyan and the organizing committee of the 11th International Congress for the Armenian Association of Plastic, Reconstructive, and Aesthetic Surgeons for giving me the opportunity once again to present today on a topic that is very much at the forefront of my practice, and that is the management of the facial paralysis patient. Just as a quick background, I am a plastic and reconstructive surgeon practicing in Beverly Hills, California. My specialties include facial paralysis reconstruction, facial reanimation, neurofibromatosis, as well as pediatric plastic surgery. Today, I wanted to talk specifically about the world of facial paralysis and how do we manage these patients from beginning to end. And it's always informative to talk about what is the definition of facial paralysis. How do we define it physically and in words? Well, first of all, it's damage to the facial nerve, cranial nerve 7, as we all know. It can be either a partial or a total paralysis. It could be on one side or both sides of the face. And it can be either an acute or a chronic event, as well as numerous origins from acquiring it later in life to being born with it as a child. The facial nerve emanates from the stylomastoid foramen as it exits into the face. It originates in the brain stem and it innervates all of the muscles of facial expression. In total, approximately 20 muscles with key functions of eye closure, lip closure, speech, swallowing, and smile being primarily affected. So moving on to how we diagnose facial paralysis. It's not as simple as identifying a droop and calling it a paralysis, but there is more involved. Famous American physician known for his study of medicine has once said, diagnosis is not the end, but the beginning of practice. And I think that highlights this particular concept very well when we try to understand and diagnose facial paralysis first and foremost. Of course, going back to medical school, the primary key element of any of this is history and physical exam. The history must be thorough as well as that physical exam, and that is the primary way of diagnosing facial paralysis and its subsequent evaluation. When we're thinking about the history and physical exam, we're really focusing in on the timing of the paralysis. When did it set in? And also taking note of the severity. Is it a mild paralysis? Is it a weakness? Or is it a complete and total paralysis? And then we move on to diagnostic studies, which can include a brain MRI to rule out certain causes that are cerebral in nature, such as this acoustic neuroma shown here on the MRI on the right. Then we can think about doing things like nerve conduction studies or electromyographies. However, these latter two diagnostic studies I have not found a large application for when we decide that someone has facial paralysis and want to warrant a type of treatment. And I'll talk about that a little bit more. Going along with the diagnosis, we want to understand what are the sources of facial paralysis. And as you can see, there are numerous, from being born at birth with the condition, trauma as being the causative agent, and of course the very common Bell's palsy or the idiopathic variants, tumors we touched on, as well as multiple other neurologic and infection sources that can result in this. And we can see here a famous American Indian, Esadawa, with his picture way back in the early 1800s showing his particular facial paralysis or Bell's palsy. Now, timing. Now, this is a very important aspect of any peripheral nerve injury, but and this also applies to the treatment and intervention for facial paralysis. And it really determines what's our strategy going to be. And the way I like to look at this is paralysis occurring in the early phase or in the late phase. Of course, there's an intervening intermediate phase, which is sometimes difficult to understand where that point might be. But in general, we discuss early interventions, or I'm sorry, early paralysis as that which has been in place for approximately 12 months, or late paralysis, which has been past the 12-month mark. And there are certain reasons for why we want to classify it this way, and it really has to do with the potential for reinnervation, where it is possible in the early phase, it is not possible in the late phase, and that is the key difference, and that dictates what we are able to do as plastic surgeons, whether we are able to perform nerve transfers to regain near total control of the facial muscles, or do we need to transplant a muscle in addition to nerve transfers or instead of nerve transfers. So now that we've diagnosed the source of the facial paralysis, ruled out other very critical sources of facial paralysis such as stroke or a tumor, we want to now analyze that paralyzed face. And I like to analyze the face into thirds, whether it's a cosmetic case or even in this situation with facial paralysis. I like to divide this into thirds. The upper third being the forehead, middle third are the eyes, and lower third are related to the smile and lip function. And these are the critical functions within each third. And we want to note the activity both at rest and with animation. So looking at the upper third, we see a lack of forehead elevation, of course, and the telltale signs of loss of wrinkling. Brow ptosis can also result in a visual field obstruction in the setting of facial paralysis. With the middle third, we have issues with eye closure. So poor eye closure can lead to keratitis. It can result in this type of scleral show, tearing of the eyes, and chemosis, some of which are very grave concerns for the eye itself. In the lower third, we're looking at the smile symmetry mostly, and the mouth symmetry. Smiling being the most recognized function of the lower face, we see a certain pattern of smile asymmetry with unopposed contraction towards the contralateral or unaffected side, and shifting of all the main landmarks of the lips towards the contralateral side. And with it goes some really interesting problems related to lack of the ability to close the lips or control the lips, including things such as with speech compensation, where the lower lip depressors are absent, and there's a habituation pattern of speech that comes by people essentially talking out of the corner of their mouth. In swallowing, propelling the food back into the posterior pharynx requires the use of the buccinator, and we see that food will sometimes accumulate in the cheek, and patients will physically have to put their finger in to push it back, or get very creative with their tongue and pull it back. Drooling can also result as the inability to close the lips. Now, we've evaluated the face, we've diagnosed the source of the problem. Now, how do we determine what treatments are available for facial paralysis and which ones should we institute? But it's good to get the overall big picture first. Do we have an early or a late paralysis? Is it a weakness, or is it a total paralysis? All of these issues matter, and it's important to get the big picture of the patient before we begin. Now, we always want to try the most conservative or easiest options. Beyond observation, we look at medical treatments. So for instance, in the setting of Bell's palsy, standard treatment these days is the administration of corticosteroids for a pulse dose followed by a short taper, as well as approximately a 10-day course of antiviral therapy, going along with the observation. In this type of condition where Bell's palsy is suspected, it's really only useful in this early period. In other words, if the Bell's palsy has set in for a number of days or weeks even, then this intervention will not necessarily yield a fantastic result. Now, assuming that medical treatment has failed, and as you can tell, there aren't many medical treatments that would be recommended. Even physical therapy in the beginning has limited use. For myself, in my practice, I do not institute neuroelectric muscle stimulation or any type of TENS unit application, because I feel that there is a possibility of worsening of a problem called synkinesis, which is a miswiring of the facial nerve upon reinnervation. Well, and it does not imitate or mimic the normal pathway of the facial nerve stimulation to the facial muscles. So after we've determined what type of paralysis we have, whether it's an early phase variant or a late phase, we then can decide in a general way that we either need to go the way of nerve transfers or the way of muscle transfers. So these are early options that are possible and have been written about in the scientific literature. Most effectively is the masseter to facial nerve transfer, the masseter nerve being located just deep to the, just inferior to the zygomatic arch and deep within the face, is in relatively good proximity to the trunk of the facial nerve and its various branches, and can be utilized in this fashion to provide motor innervation to the distal branches of the facial nerve. Similarly, the hypoglossal to facial nerve transfer is possible, but less favored due to a non-analogous way of stimulating the facial nerve. And finally, going along with this is something called the babysitter procedure, where the masseter facial nerve transfer is combined with several cross-face nerve grafts from the contralateral face, or the contralateral working facial nerve, towards the branches that are being reinnervated, with the idea that the masseter to facial nerve serves as the babysitter mechanism of maintaining the motor end plates of the distal branches of the facial nerve, where they insert it to the muscles, as the native stimulation from the opposite facial nerve travels through the cross-face nerve graft and is simultaneously connected to the distal branches of the paralyzed facial nerve. So this is an example of a masseter to facial nerve transfer, as demonstrated by Klebuck and PRS in 2011. He shows here that the masseter, where approximately the masseter nerve emanates from the sigmoid notch of the mandible and travels into the deep surface of the masseter muscle itself. It is a dually innervated muscle, whereby we can sacrifice one of those branches and deliver a very solid innervation into the non-innervated distal segments. And as you can see, the proximal segment of the facial nerve, which is no longer working, assuming a more central reason for the paralysis, has been transected here. So this is an example of a nerve transfer. A 16-year-old with a temporal Ewing sarcoma had several branches of his facial nerve damaged upon removal of the tumor. And we performed a masseter facial nerve transfer in a babysitter fashion with several cross-face nerve grafts. And as you can see, after 2 years, we're seeing better stimulation of the paralyzed side of the face. Now he is clenching his teeth in this particular picture. Some of the downsides is that we got aggressive eye closure on this side now, where it was mild previously. In addition, we are seeing an excellent nasolabial fold developing, as well as improved lower lip depressor activity. And this is a typical type of result from something like this. Here's another example of a 2-year-old female with an idiopathic onset of a left facial paralysis. We watched her for 6 months, and she failed to recover spontaneously, fearing that she would be past the point of proper innervation, and the fact that she had not demonstrated any reliable reinnervation, we decided to proceed with a masseter to facial nerve transfer with babysitter procedure. You see here the facial nerve trunk as it emanates from the stylomastoid foramen, and the masseter nerve in the face. And when we rotate and move the trunk of the facial nerve more proximally, it has been transected at the stylomastoid foramen, and the masseter nerve is brought into proximity, and a suture repair is performed in the mid-face. And 3 months post-op, we're already seeing a wonderful recovery of that particular facial nerve. Here's another example of someone who had a partial facial nerve paralysis, and essentially did not recover with conservative means. And he was in the intermediate phase, which prompted us to get some nerve conduction studies to demonstrate if there is any activity in the neuromuscular end plates to warrant a nerve transfer. And we did see some activity. And so we proceeded with a babysitter procedure, and you can see as he activates his masseter nerve now, he is stimulating his facial musculature once again. And you can see he's trying to coordinate this because this is mainly an analogous muscle. It is not his native mechanism for triggering the facial muscles on his paralyzed side of the face. However, with time and facial rehab, we are able to get movement back into that area. So moving on to the upper third of the face, when we think about moving on to the more of the static options, where nerve transfers are no longer an option, we can perform very focused types of interventions. So for someone with brow ptosis and a lack of brow elevation, we want to perform a typical static procedure that can result in improved function there. In this case, it was a brow pexy procedure where the brow was elevated into a desired position, and as you can see, it was very much stabilized in the postoperative period, and it has been maintained even further on. When correcting brow asymmetries, sometimes we can perform a contralateral frontalis strip resection. In other words, we can remove the active brow muscle, and we can do this either with Botox or this strip myectomy, as you can see here, and that involves essentially removing a strip of the frontalis muscle. In this case, a coronal approach had been performed for for a simultaneous temporalis procedure, so we were able to do this simultaneously, and we remove a segment of the facial muscle, of the frontalis muscle, leaving a gap in order to avoid any elevation on that side or excessive contraction. In the middle third, we really focus in on the upper eyelid function mostly in order to help the eyelid descend and help close the eye itself. And the most common way to do this is with insertion of a gold or platinum weight. Sometimes a spring is placed, and sometimes we can do something called a levator lengthening by using a strip of temporalis fascia or another piece of fascia to splice into the levator mechanism, thereby lengthening it and allowing the upper eyelid to descend further in the correction of LAGOPHTHALMOS. Frequently, I will combine upper eyelid procedures with lower eyelid procedures. As you can see here, the paralyzed eye will often have a droop at the lateral aspect of the lower eyelid itself, and the eye itself obviously does not close all the way. In order to help or assist the upper eyelid close the eye, we have to lift the lower eyelid simultaneously, and that's done in several ways. And my preferred technique is using a tendon sling, preferably a palmaris longus tendon sling from the wrist, anchoring it to the medial canthus, and also anchoring it just above the lateral canthus with a certain amount of tightening to not only elevate the lower eyelid, but slightly overcorrect it to a degree. Others may recommend tarsorrhaphy if this is a milder variant of facial paralysis or just a facial weakness. And sometimes a mid-face lift can elevate the cheek tissues and help bolster the the lower eyelid, and improve the eyelid functioning. And here's an example of this type of dual correction. This 16-year-old was unable to close her eye due to facial paralysis from resection of a brainstem tumor. And we performed this exact procedure with insertion of a gold weight in the upper, or a platinum weight in the upper eyelid, with simultaneous temporalis tendon sling. And as you can see in the resting phase, it's much improved, not only in eyelid position, but also, upper eyelid position, but also the lower eyelid position. And you can see the shadow of the weight here. We get much improved eye closure, and shown here at post-op 9 months. Now, moving on to the lower third of the face, we really talk about smile anatomy. And really, there's no fantastic way of describing smiles other than there's 3 general classifications according to Rubin, in which case we have a type of Mona Lisa smile on the left here, all the way to a very wide open, full tooth smile or a canine type smile in the middle. So we want to correct symmetry as much as possible. And one of the things that I like to perform is either a chemo denervation with Botox quite frequently, and in some cases for children or in adults who no longer wish to receive Botox over the rest of their lives, I perform a lower lip depressor myectomy, really targeting the depressor angularis oris and the labii inferioris muscles, which are these two particular muscles. And this is the approach through the buccal sulcus. Here's the mental nerve skeletonized and preserved as we proceeded past to strip out those two particular muscles, which are much more close to the skin than people realize. And here are a couple examples, and it's often obvious. It is often an adjunct type of treatment in addition to, let's say, a smile reanimation procedure. Both these patients have undergone smile reanimation, but simultaneously underwent a lower lip myectomy procedure, as you can see here. It balances the lower lip out. Is it perfect? No, and sometimes we have to repeat the process in order to really denervate that particular muscle. And the way that I do it nowadays is not only take a strip out, but also denervate that muscle. Now we go into the dynamic options. What are these dynamic options? And the main one that most people discuss is the gracilis transfer. It's either using one stage, connecting the nerve to the masseter, or doing it in two stages by first laying down a cross-face nerve graft several months before. And this is what the cross-face nerve graft looks like. Typically, my technique is taking it out through 3 stair-step incisions. We get a very long, narrow piece of sural nerve that we can transplant into the normal facial nerve side and then connect it to the desired branches for activating the zygomaticus major and minor muscles. And we do that by testing the muscle during surgery. And this is a sort of a pictorial of what that might look like inside the face. And as the anterior edge of the parotid is encountered, we see the arborization happening of the facial nerve and all its branches, and we can stimulate them individually, even draw out various interconnections that can happen, and we visualize that effect on the face. Now, once we've done the cross-face nerve graft and we've determined that there is decent innervation, we come back in about 9 to 12 months roughly and perform the second stage, which is actually moving the gracilis from the thigh into the face. And you can see this in situ gracilis here. The nerve is outside the body there. And in this particular picture, I'm showing a stimulation of the nerve and a contraction of the muscle. And here's the inset inside the cheek with vascular anastomosis to the facial vessels. And this is what a 2-stage might look like. And as you can see, it's not a perfect result. We don't see a very nice nasolabial fold. There is continued asymmetry and weakness of that particular smile. There is some cheek bulk that is developed as well, which is more accentuated with smiling. Here's another example of the gracilis in 2 stages, and again, similar type of a result, except with a little bit more contractility of the muscle, again through by the means of the cross-face nerve graft. Now, we can also use the masseter nerve, and I showed previously where that originates deep underneath the zygomatic arch and along the temporalis fossa. And this is what a gracilis nerve might look like to the masseter nerve, and it does require clenching of the teeth to get movement. But as you can see, this is a fairly good result. We get a secondary mid-face lift here, which is an interesting finding. Whenever we animate the face, whether it's with a temporalis technique or a gracilis muscle, we sometimes will get the benefit of a mid-face lift without even trying. And that's the result of reestablishing tone in the face. And this has no eye work involved with this. In other words, no ptosis correction surgeries there. So this is a typical result. However, you can see that there's some bulkiness of the cheek, an unusual dimple in the mid-cheek of that face. And again, this has been a very well-tested option over the years. And this is just a typical result of this particular patient showing her control. She has to think about contracting that muscle a little bit more to get more action. We can use this for Mobius syndrome as well. We have to use one side and then do the other several months later. And this is what typically this might look like. And here's this child trying to smile in this picture, and then she will try to do this. Now, this is 6 years after bilateral gracilis, and you can see the cheek bulk issues. Overall, a fairly good result, but the cheek bulk was a little bit much for that particular patient. So this led me to re-explore certain avenues and improvements in smile reanimation surgery, which took me on my training days to Dr. Daniel Labay in Caen, France, and he was already performing the lengthening temporalis myoplasty, which involves moving the muscle in a rotational fashion within the temporalis fossa and making it travel underneath the deep structures of the face and connecting through a counter incision at the nasolabial fold. And I published my particular findings in April 2016 on this technique. And this is what that looks like intraoperatively. Here's the muscle mobilized and re-anchored in its new position along the temporalis fascia. It is brought out through the nasolabial fold incision and then subsequently anchored after removing the coronoid process. And this is what the patient looks like at 2 weeks, at 8 weeks, and then at 2 years. So we see that after 2 years, we're able to see some sustained results. Her particular scar is a little bit deep right now, and that can be revised secondarily. She's also had a couple of tiny revisions done to help improve the contractility of the smile. And this is what this patient looks like, again, at one time point of her postoperative period. And you can see she's actually activating that smile very nicely. Another example of the temporalis myoplasty procedure in this particular patient. Here we are at 4 weeks, and she's really demonstrating excellent control of this particular muscle. And I'm having her speak to see how that muscle moves in non-smile type of functions. And here she is again much later, at about a year. And she's showing excellent control of the muscle right there. She's sort of moving one side, then the other. You can see it's not perfect. It cannot reestablish the orbicularis oris function in terms of puckering. However, she's able to achieve bilabial closure by activating the muscle, which is an important feature that helps her speech. And another patient with who underwent a bilateral simultaneous temporalis lengthening myoplasty for Mobius syndrome. And this patient did quite well from this particular procedure, and he only had the one procedure to achieve this particular result, which was quite satisfying. And another view of a Mobius syndrome patient with a preoperative smile and complete lack of contractility in the paralyzed portion of the face. In this case, it's a unilateral case. And here he is 10 months after the lengthening temporalis myoplasty, showing some pretty good control. So in lower third reanimation, it's important to know, why would we choose one surgery over another or vice versa? And there is no right answer to this other than whatever works for that particular surgeon's experience. So in the temporalis case, it's one surgery typically, whether it's bilateral or unilateral. In gracilis, it might need one or two, whether it's bilateral or unilateral. There's no spontaneity in the temporalis. This is a muscle of mastication that we're using. In other words, it needs muscle retraining. In the gracilis, if you use a cross-face nerve graft in 2 stages, it is possible to have spontaneous smile through the contralateral normal facial nerve. When we talk about cheek bulk and cosmesis, temporalis muscle does not really produce much bulk in the cheek because we're not adding volume to the cheek. These are muscle transfers that occur deep within the face and not in the subcutaneous plane. Whereas in the gracilis must sit in the subcutaneous plane, and it can thereby add volume to the cheek, which gets accentuated with activation of the muscle. Adjustability of the smile. I think this is a very important part of any type of dynamic procedure. Can you adjust this? Can you adjust the results based on how much is the muscle contracting? in the setting of the temporalis, I perform this intraoperatively. I stimulate the muscle after it's connected to see how much movement we have, if it needs tightening in any location, it needs a replacing of any anchoring sutures. However, in the gracilis, this is uncertain. We set our anchoring points, and we have to accept that particular outcome. We can, in certain small circumstances later on, revise and improve those, the insertion sites of the gracilis, but this is not a very easy task. When we talk about when does a smile occur, it can occur between 2 to 8 weeks in the setting of temporalis myoplasty, or 3 to 12 months in the gracilis. 3 months being if it's a single stage gracilis to a masseter nerve. Nasolabial fold, which is such an important part of smile anatomy, is very accurately placed by placement of the nasolabial fold incision. It really defines the fold itself, as well as giving us very important access to the anchoring site of the temporalis tendon insertion. Whereas in the gracilis case, sometimes this is not as predictable where the fold will generate. As you saw in the previous photos, we get dimpling sometimes in the mid-cheek, which is hard to correct, and sometimes the fold is dragged in that direction. So my technique that I wrote on was actually published in PRS last year, and in fact did receive the best reconstructive award paper in all of 2016, which sort of gives validity to the fact that this is actually an interesting procedure. People are recognizing this as a viable option for not only children, but anyone with facial paralysis who does not want to undergo a lengthy procedure to have their smile back. So in that study, we looked at 18 temporalis myoplasties in 14 patients. We noted that there were shorter operative times when we compared it to gracilis options. There was no ICU requirement in any of these patients. There was improved time to reanimation. However, there were certain drawbacks, and I think the biggest drawback is right here. We saw a very high revision rate, really related to avulsion of the temporalis tendon insertion site at the nasolabial fold, and sometimes adhesions within the deep tunnel of the face, which limited the excursion of the muscle. Now, this high rate has now been reduced substantially. However, in that early period where the study was performed in a 2-year setting, this was observed. The revisions were quite simple. They were same-day procedures. They did not involve reopening everything, and in fact resulted in an excellent recovery of smile function. So I'm going to conclude a little bit by just reviewing some of these concepts. So one of the important things to look at is, when do you refer someone? So for the non-plastic surgeon or the person who does not perform facial paralysis reconstructions, we need to encourage our colleagues to refer at the moment of the paralysis. It's okay to try to initiate treatment by way of steroids or antivirals, but what I commonly see in my practice is a long delay to actually getting treatment, so that we are often not in the early phase of treatment. We are actually entering the late phase, and in general, reconstructing the late facial paralysis face is a much more complicated process with much less desirable outcomes than if you can do a nerve transfer in the early phase. So we want to diagnose the problem. So history and physical, incredibly important, followed by the diagnostic studies, keeping in mind a very wide differential diagnosis. We want to establish the timing. When did this facial paralysis begin? We always want to catch this early. When we can perform a nerve transfer and regain full function of every branch of the facial nerve, this is the ultimate outcome. And it's possible. The issue once again becomes changes in referral patterns to help our neurology colleagues and family practitioners, pediatricians, anyone who comes across facial paralysis on a first-line basis, to help refer them right away to a specialist. We want to evaluate the face into thirds. We want to look at the upper, middle, and lower thirds. We want to start early treatment, if possible, which is less than 12 months, with nerve transfer, or if we're already entering the late phase of treatment, or if we're getting nerve conduction studies to determine viability of the neuromuscular motor end plates, then we may be entering the late phase at that point, which will necessitate a muscle transfer option, as I've outlined with either the gracilis or the temporalis. I want to thank everyone for listening to my talk today. If you have any questions or need to reach out to me, if you have a patient you need to refer, these are some of the contact places you can go to. I'm also on social media, where you can find me on Facebook, Instagram, and Twitter, as well as some other venues. Thank you very much.